And so we hope that this is a useful session for all of you and will help prepare you for your final quiz with Professor Banguti. And so as usual, we have Professor Banguti from the University of Rwanda. And today we just have Dr. Francois Xavier from King Faisal Hospital to support. And so with that, I'll pass it on to Professor Banguti.
Thank you very much, Alana. Thank you very much, the whole team. As you all know, this is the last session of the series, and it's mostly frequently asked question. I will be on trying to summarize all we've been discussing throughout the whole year. I'm thankful to starting by the all ECO team, be it in India or in Canada or in the US. Thankful to the University of New Mexico. Thankful to Anna, Anna Crawford, my friend. We've been together throughout the whole journey. We are thankful to Monica and the Indian team and Oge, who has joined us just recently. I'm very thankful to all you've done for this Rwandan hub to be so successful. Thank you to the whole audience. I know some people we've been together since the very first beginning, the very first day, who are still here. And I'm sure even if you had another day, they will be there. So thank you very much for trusting in us, trusting in our knowledge transferred through this method. And we hope there will be another chance to continue. So as you know, it was planned since the beginning. This course will have some CPD points. The first part was the full session. We had the quiz, and for those who succeed the quiz and those who had at least 75% of attendance, they received the certificate with 10 CPD points. So the following 8 sessions, which we are ending today, 75, the same rules, 75% of attendance and 74% of pass mark, you will have the remaining 20 marks, 20 points of CPD. So there will be a small quiz. Maybe we'll discuss with Alana, maybe in 1 week. We know it's the end of the year, people plan their leaves, but as you know, it will be a free attendance, meaning we can open up the session for stretch it over 24 hours, so everyone can attend on his convenient time. So maybe at the end of this session, we'll agree on the date. I'm suggesting 29th, so next Wednesday, 29th. So up to you, suggest otherwise, and prepare yourself, and also inform other colleagues who can are ready to try the quiz. So we are starting today. It is questions and answers. So we want it to be participative and also people to learn from this session. So question number 1, it's next session, please. So maybe back just to introduce a little bit. We have 5 chapters we are concentrating on. The first is oxygenotherapy. The second is on critical care. The third is on COVID-19 and obstetric care and pediatric care. Those are the sessions we've been discussing. So we'll frame our question around that. So question number 1, it's the first part will be next slide. The first part will be true and false. So you answer the question by true or false. And the second part will be on a multiple answer question. So on this very first part, let us start question number 1. So when you see the question, please answer in the chat, and we will see percentage of people who are true or false. And then we go through explanation of the answer before agreeing on the right answer. Clinical signs are not reliable, predictable of hypoxemia. Is it true or false? So Alvin, can we do the averaging the answers and know how many people are on true or false? So clinical signs are not reliable as predictable as predictors of hypoxia. So what do you think? People are saying true. So truth means they are not reliable. No one for false? So, okay. Next slide. Some patients may be hypoxic without obvious respiratory distress. Other patients may not show clinical signs until hypoxemia become severe. And you remember we discussed on the AP hypoxemia, especially during COVID and other conditions. So, next. That's true. So Alana, can we use the method where we can know how many people are on the good side, bad side, so that we know?
Yes, yeah.
So question number 2, Sumeya, a 4 years old female child, present with cough and fast breathing. Cough and fast breathing. Oxygen saturation by pulse oximeter read 88%. Does Sumeya have hypoxemia? Cough, fast breathing, and a pulse oximeter of 88. Does she have hypoxemia? Is it yes or not? Say no. Someone say no. No. Please try.
Alvin, are you able to launch the poll on your end or Unish?
Alana, just give me a second, please. I'm not able to launch the poll from my side.
So next slide. Hypoxemia is defined as by SpO2 below 90% for most patients. So what do you think? Was it true or false? So the answer was true, because that patient had a SpO2 below 90, so it is hypoxemia. Next. Next slide. So question number 3. Normal oxygen saturation range from 80 to 98. True or false?
The polls have been launched. They can just answer from the polls also.
Please answer from the poll. So normal oxygen is between 80 and 98. Is it false or true? I can see the false is 73%. The true is 27%. Only 11 people answered. Please, others, just participate. We want to see if at least we are understanding what we've been learning. So I can't see my slide. Maybe something happened. Alvin, I can't see my slide.
Just
At least,
just a second, doctor. Alana, are you able to share the screen?
Yes, sorry, I got kicked out of the meeting. I'm back, so slides are up.
thank you very much. So as you can see, we have 30% of the group which say it's true. Next slide. Hypoxemia is defined by SpO2 below 90 for most of the patients. So normal oxygen saturation is above 90%. So before we go to the next slide, do you think people will say true? Can you argue? Can you say something? Because for me, that when I were composing this question, it was obvious. So the 33% of people who say it is true are puzzling me. It's just I don't understand how at this level, at where we are, we can really accept that someone who is between 80 to 89 is normal. That is someone who is dying. So, hope we agree on this. Please realign your mind. Hypoxemia is below 90. You can't be normal with 80, 85, 88. Next. Next. So a good way to ensure accuracy for the recorded saturation of a patient connected to a pulse oximeter is by visualizing a regular pulse wave for 30 seconds at least. Is it true or false? Is it true or false? So you have to be sure that you've seen it very well. You need to make sure for 30 seconds your wave is being normal, a regular wave, sinusoidal wave. So we have people who say false. I wish one of you could explain to us why is it false? I wish I could have an explanation. Is it possible to unmute and explain? One of the people who think this is false, can you unmute and explain something? So next. So you see, when you put your pulse oximeter on the finger, sometimes you just have a number. That number can be low or high, but you don't see very well the curve, or it's not regular, it's not sinusoidal like this one. By the principle of functioning, the function of the pulse oximeter, you have to have a sinusoidal curve because it is about fraction of two numbers. So you need to have such curve, which is sinusoidal, then you can confirm the number you are seeing. And you need at least 30 seconds to watch a normal curve, stable number, then you can confirm that you are on it. Next. So it's true. Question number 5. Blood gas analysis is more accurate than SpO2 for detecting and diagnosing hypoxemia. True or false? Blood gas is more accurate. True or false? So we have 20 people who have answered. The total participants is 37. Only 20 have answered. And we can see 20% of people say it's false. So they think pulse oximeter is more accurate than the blood gas. I wish I could have an explanation on that. So next slide. Blood gas analysis is more accurate than SpO2 for detecting and diagnosing hypoxemia. So can you write in the chat if possible, or can you unmute and argue against this explanation? Because I can see 20 people don't agree with us. 20% of people. At least if there is any question, please put it down. Maybe at the end you can answer, you can ask, but it's obvious that some people with some abnormality on the hemoglobin or some abnormality of oxygen fixation can show you still the good pulse oximeter while they are hypoxic. Just in case of intoxication on monoxide or carbon monoxide, you can still be having normal pulse oximeter while hypoxic, because the monoxide of carbon monoxide has the same length width as oxygen. So it displaces oxygen from hemoglobin, fix itself, and because it has the same length width, you can read like 100%. But patient is hypoxic. The same, it happened in intoxication, it happened in smoking patients. It can also happen for other agents which are intoxicate the hemoglobin. The same for some people with metabolic acidosis in case of HIV, where the mitochondrium is not functioning well. You can have a good, false 100% SpO2 while they're hypoxic. So someone say we can't see your slide. Next slide. Oh, that's a mistake. That's a mistake. I think in come back. It's true because the blood gas is more accurate. So don't consider it. Maybe it's a typos mistake. Don't consider this. Typos mistake. I wish even I can correct it. Alana, can you correct for me? It's a mistake. Typos error. Don't trust it. It's true. Blood gas analysis is more accurate than SpO2 for detecting, diagnosing hypoxia. So it's true. So next slide, please. Can you answer this? Hypothermia and poor perfusion can affect the pulse oximeter reading and accuracy. Is it true or false? So I can see 28 people have answered the question. That's good. Good participation. Among them, 27 disagree, are saying it's false. So that is questionable, because in the function of the pulse oximeter, when I remember 8 months ago when Honorine took us through the how the pulse oximeter function, we learned that time about factors limiting the good reading of pulse oximeter, and hypothermia and poor perfusion were among those which can affect. So it should be true. Next. So hypoperfusion and vasoconstriction can decrease the accuracy of the SpO2. So this announces the answer. Next. It's true. So if any argument, please put it down. We shall discuss at the end. I wish we could have time to stop and discuss, but it seems like people can't unmute and talk. Next slide, please.
People are welcome to unmute if you're able to.
If there is no pulse oximeter available, clinical signs can be used to guide administration and titration of oxygen therapy. True or false? So you can see 26% of 26 people participated, over 35 participants, and we have 14% of false. I wish I could have an explanation how this can be false. Next slide. Remember signs of hypoxemia. We had the rat on the bed, restless, agitation, tachypnea, tachycardia. Those can be signs. The late signs are bloody, extremity cold, and distress, or diaphoresis. So those are late signs. So if you have such signs, you can, not 100%, but at least they are among signs of hypoxemia. They can also be caused by other dysfunction. So if someone is put on oxygen and you see he was bloody and is coming back to normal rate, normal breathing, normal extremity, normal cold extremity, normal distress, and is becoming just, is no longer restless, is becoming calm. So you can come from 10 liter on oxygen mask, 10 liter on high flow, so 10 liter per minute. You can go down to 5 and start decreasing, start going down. So if someone is in distress, you give him oxygen and the distress is gone, is less distress, that can be a sign of good evolution. It means patient is not more hypoxic, so he's becoming just less hypoxic, or is even being normal. So you can, the clinical signs can guide. Next slide. True. Next slide. Simple facial mask of oxygen use limited to flow below 6 liters per minute. True or false? So you can see among 36 participants, only we have 26 who have answered, and half of the group say this is false. So Next slide. Simple facial mask can be used with flow of between 6 and 10 liters per minute. So I hope you remember that we start with 5 or 6 liters per minute. You can go up to 10. And the more we go up, the more the FiO2 goes high. And we said it was ranging from 40% FiO2 up to, we can go up to 60% using the facial mask, 40 to 60%. And when we need more, we change to facial with reservoir. Then that we can keep 10 or up to 15. Then we can escalate up to the non-rebreathing. So it's not below 60. Actually, when you are below 5, you can use the nasal pump. So meaning the answer was no, was false. So we can go higher. So we have more than 50% who would say it true. So those are the people I would like to have time to discuss with them. If they can unmute and argue, that's good. If they can't, keep it for the end of the session, can have a good discussion. For this question number, I think it was, which number? Okay, so next slide, please. So that one, the other one, it was not question number 8. At the end, I would like to have more arguments on question number 8 because more than 50% of the group said got it wrong. So we need to discuss. So we have this question: room air content 21%. Is it true or false? Only 10 people participate. So we can see there is there is a sound from Kenneth Ralimo. Okay, good. So I can see only 14 people participated. I'm wrong. I used to make it double to say it is 28. It's 14. So among 14 people who answered, there is 14% people who say it's false. Next slide. True. So such question, the answer is obvious, true, unless people who say it's false went further, went too deep into the question and say maybe there is in the room a pollution, maybe there is another gas which has been put in the room, so like monoxide of carbon or something else which is polluting the room and made it less than 21. But 21 is then for a normal room air, what we have in my room, in your room to survive, it's 21%. So it's true. Next. Sedation, traumatic brain injury or stroke can lead to hypoxemia. Sedation, traumatic brain injury, or stroke can lead to hypoxemia. Is it true or false? So You can see 13 answers. And there is one person who say it's false. 2. He says sedation can't. Brain injury can't. Stroke can't lead to hypoxemia. Next. So we have a hypoventilation effect from inadequate breathing will fail to bring oxygen into the lungs. Clinical example includes oversedation, central nervous system injury, such as stroke or brain injury. If people who said it's false were thinking about a small dose of sedation, small dose of propofol, small dose of midazolam, which can't lead to hypoxemia because it happened, and even when we sleep normally. But when they say sedation and brain injury and stroke, so they are guiding you toward a condition where the breathing pattern can be impaired and there will be hypoventilation. So when there is hypoventilation, it will cause hypoxemia. Next. It's true. Next. The fraction of inspired oxygen in air is 21%, whether you live at the sea or in the mountain. True or false? Okay, I can see among 10 people who are answering this question, there is 25% of people who say it's true. It can be at the level of the sea, or you can be in Ethiopia at the higher mountain. It's true. But some people say false. If you are, the higher you go, the lower the FAQ2. Next. The normal value of the fraction inspired oxygen decreases with an increase in altitude. Therefore, normal oxygen saturation is less for our friends that live in higher places like the island of Peru, Tibet, or Ethiopia. So, answer is false. Next. Oh, that's wrong. That's a typo's error. And it's well explained. When the higher you go, the fraction will go down. It will not be 21, it will be below 21. That's why the more you climb the mountain, you feel like you are getting asphyxiated. So it's false. Next. Oxygen can be toxic to premature infants. True or false? Oxygen can be toxic to premature infants. You can see among 19 people, 19 people will answer this question. We have a number. We have 4, meaning 21% of people who say it is false, can't be toxic. Next, please. neonates born at least less than 32 weeks gestation can develop retinopathy or prematurity and neurological complication when exposed to higher level of oxygen. So it's true. If any argument, please, at the end, just we shall come back. It was false. Clarice, Mutoni Clarice, can you clarify what you're saying? So it was true. So there is some typos error from the preparation of those slides. So that's why we wanted to have explanation and answer. So you can see on the explanation, it is obvious. Okay, next. Question number 13. So after this question, I think my colleague will take over. Francois will take over, starting the question 14. I think it will be 14. No, you will start at 15. So please be prepared. You start at 15. An increased work of breathing with a respiratory rate of 27 breaths per minute is always an indication of supplementary oxygen support. Is it true or false? So I can see there is a 38% of challenge who think it is false. Next slide. Increased work of breathing is not always pathologic. The best example is increased work of breathing during exercise. However, if the increased work breathing is not suitable or is associated with impaired gas exchange, then oxygen therapy is indicated. So the challenge can be considered. If you are in a normal condition and you have the work of breathing, you have rate increasing without any exercise, or in babies up to 1 year, they can breathe at 27, or some obese who have developed some shallow breathing due to obesity and other conditions. But a normal patient, maybe the question was not clear. Now, a normal patient who didn't do exercises is developing increased work of breathing without any history of exercises or chronic disease condition, that should be true. But in other conditions, it's false. Next. So it's false if we don't precise the question. We need to precise if the patient is normal patient, aged above 1 year. He is not obese, who has developed a shallow breathing. He is not a COPD patient, and he is not coming from exercise. But if there is no explanation of those conditions, the answer is false. I know there will be some arguments, but we can still discuss on it. Question 14. Hypercardia is usually a strong stimulus for breathing than is hypoxemia. True or false? So we have 20 people who've answered question, and 24 of them say 25 people or 23%. The quota of the group said it's fast. Next slide. It's important to note that chemoreceptors also detect and respond to pH and carbon dioxide. Hypercardia is usually a stronger stimulus for breathing than is hypoxemia. So it is true. Next. So the next step will be guided by Francois.
Yeah, thank you. I think before I join, we have to take notes to question 8 and question 13, where most of our responders need more to react on them because the answers were not really satisfying. So we're now going to talk our series about multiple choice questions. We're still using the same method of pooling. So I would like to ask the IT team for the next question. The audience, you have 1 minute to think about and give us an answer before we discuss the correct one. Thank you to everyone. The answers you gave are like 47% are for E, and 26% are still working on. 26% are for C. Let us have a short discussion on this. Yeah, we are still having more around 50% on E and 25% in C. Let us see why most of us here, wait, please. Most of us here are working in health facilities where maybe in order that you don't have the bag valve mask, but I think in maternity, you are having it, the small for resuscitating the babies. And the tip of answering such multiple questions, like when 2 answers or 3 are correct, and you have all the above are correct, you have to think more and think twice why we say all the above are correct, and among the above 2 or 3 are looking like correct. Let us discuss about the bag valve mask are used to manually deliver positive pressure breath in a patient who have increased work of breathing or low oxygen pressure. So I'm not going into details about what is positive pressure breath, but usually we are breathing as in negative pressure. So when you are giving a breath, by giving that pressure of supporting using the bag valve mask, you are giving that breath by positive pressure to reduce or to help the patients not use the rambling breathing, as we say, in the saturation patient. A is correct. For some people who answered correct, yes, A is one of the correct answer. Second, the bag valve mask ventilation can be used in apnea or hypoventilating patients. Here also, remember in the previous false or true questions, where we said in sedation patient, in hypoventilating patients, those people are hypoxemic. So as you know, hypoxemic patients are treated by oxygen, and the oxygen delivery, they has multiple choice by using multiple devices. The bag valve mask can be helping that patient in apnea by positive pressure. They are going to give oxygen, or hypoventilating patient. B also is one of the right question for the people who choose them and they choose one or one. For C, has one-way valve to prevent rebreathing of exhaled air. This also is correct. If you see how the apparatus looks like, you will see there is a small kind of like membrane. When you bag, you will see its movement. C also is correct. Excessive positive pressure, when you use this positive pressure with this bag valve mask, you can lead to gastric insufflation and increase the risk of aspiration. To the audience, most of them are French speakers. Maybe they don't understand what is insufflation, but it's like when you are using this positive pressure, you are like increasing the pressure into the stomach, and from that pressure, the patient may vomit and aspirate what they are vomiting. Reason why when we are intubating a patient with this kind of, after they eat or they do something, this pressure can cause vomiting and aspiration. You will see anesthetic say that, please, before intubate, you have to fast for like 6 hours and above. So is it to prevent this kind of vomiting and aspiration. So when we have A correct, B correct, C correct, D correct, so that you cannot, is not having multiple answers in one, we have one to answer all the above. So the answer is all the above, as you are having all the above being correct. Thank you. I think it's clear for this answers slide. Next, please, for other 2 minutes to people to read and answer in our polling system. I know I give you enough time to think and answer on that. Thank you. I see 70. Okay, let's go through. Let's go through discussion about answers we are having here. Which one of the following statements is not an indication for oxygen therapy in adults? And among indication of oxygen therapy, we discussed during our 12 month discussion. A, cardiac arrest and advanced cardiac life support. I think most of us here on the platform, when we are doing CPR resuscitation or BLS, whatever is CLS, giving oxygen is very crucial here. You do whatever chest compression and you give a breath, kind of giving oxygen. So in cardiac arrest or in advanced life support is an indication to give oxygen. Oxygen saturation less than 90% by pulse oximeter. Remember in the previous slides, Professor Banguti were explaining when you have to care about giving oxygen saturation, when the choice was 80 to 98 as your cutoff. So less than 90 is an indication to give oxygen and support your hypoxemic patients. Respiratory distress with respiratory rate more than 28 breaths per minute. Here, you remember with one of our co-panelists, Honorine, we had to differentiate what is respiratory distress and respiratory failure. And at that time, the indication to give oxygen when your patient is in respiratory distress and you are not sure yet, you are still working on differentials, you have to give oxygen and then work on your differentials till you know, as Professor was explaining previously, if your patient breath rate or respiratory rate is corresponding to his activities, either exercises or obesity, etc., etc. And if you have such patient without having ruling out all those things, is an indication for oxygen. So acute kidney failure requiring renal replacement therapy. Let us think twice. Among the causes of hypoxia or type of hypoxia, and among the causes of hypoxemia, I don't think where we discussed about the renal involvement. So here, the three are indication of oxygen therapy, but the last one is for other therapy. Is either acute kidney injury, you may use fluids for the renal. Mukakamanzi mutwihanganire murakoze. The answer here, acute kidney injury or acute kidney failure is not an indication, an indication for oxygen therapy at the first encounter, unless you rule out or you had other causes when you are at the state of acute kidney injury causing the pulmonary edema. So the next slide, please. The answer here is D. D is not one of the indication of oxygen therapy. Next, please. We are still having 2 minutes to read and give an answer accordingly. Let's come back to the discussion of the answer. Here, among 18 audience, 67% of them are answering the answer is C, but 33% also of them, they are saying answer is A. Let's go one by one. Which one of the following statement about hypoxemia is correct? Increased cellular metabolism can decrease oxygen diffusion into the pulmonary capillaries. Here, the question is about what are the causes of hypoxemia, as we discussed during our session. Cause of hypoxemia, among them, we have to know where we take oxygen and how we get oxygen into our tissue. So when we say increased cellular metabolism can decrease oxygen diffusion into the pulmonary capillaries, this is a mixing of words. Diffusion is into, we are talking about when we say oxygen diffusion is at the level of pulmonary alveoli and also pulmonary vasculature, is where when you get oxygen into your alveoli, with that vasculature, there is that kind of diffusion of oxygen, of gases, and there is a gas exchange from CO2 outside, and there is O2 into the blood. This is what is diffusion. So increased cellular metabolism, we are not yet at that level. The oxygen has been into the cells, in the mitochondria. We are still on gas exchange level, so that increased cellular metabolism doesn't correspond with diffusion impairment or diffusion problem. This A is false, is not correct. When you go to the B, pulse oximetry directly measure oxygen saturation using analysis of blood gas. You remember when we discussed about pulse oximeter, hypoxemia, hypoxia, how do we diagnose hypoxemia? 3 methods, clinical signs, blood gases, and the pulse oximeter. We remember that the pulse oximeter is a non-invasive and very cheap oximetry, whereas the blood gases is invasive and also expensive. And when we say pulse oximetry directly measure oxygen saturation using analysis of blood gas, this also is kind of contradictory, because the pulse oximeter is, you place the pulse oximeter on the without invasive methods, but when you have blood gas, you have to use also the machine we call the blood gas machine or the blood gas analyzers. So these are 2 different things, working and giving results, as we discussed in our session. So B also is not correct. Hypoxemia occurs when the percentage of oxyhemoglobin is insufficient. Think twice about this. If among the causes of hypoxemia, we have one of these. But remember, occur when the percentage of oxyhemoglobin is insufficient, meaning oxygen and hemoglobin affinity or hemoglobin contact, hemoglobin binding is insufficient. This leads to hypoxemia actually, because as we discussed into our 12 sessions, when the hemoglobin is not fixing oxygen, you are getting hypoxemia. So if the binded hemoglobin with oxygen is not sufficient, of course here you are having hypoxemia. Here C is correct. And when we talk hypoventilation, does not lead to hypoxemia again. We are here on causes of hypoxemia and how we are getting oxygen into our lungs and the tissue. Hypoventilation is one cause of hypoxemia. As we said, people are sedated, people are having sleep apnea, etc., etc. So the answer here is C. Please, can we have slide, the next slide? So this I explained this is how we are getting oxygen to our lungs, how the oxygen enters into lungs and the travel to alveoli is here where I was explaining the answer about diffusion. And then when they enter into the hemoglobin, they bind on them to the hemoglobin and they fuse into the plasma. We call oxygenation. These are the process we are getting when we are talking about hypoxemia. Next, please. Yeah, I discussed about this. Can you keep next? Yeah, 1 more minute to read on that and give an answer. We are still having 2 to 3 questions also. You have 1 or 2 minutes to discuss on this, to answer on this. Once again, thank you. We're having 45% for the 28%. You are still answering. Once again, let us discuss the answers and you will find yourself what is the correct answer you have to choose. Which one of the following choices is correct? Hemoglobin is hemoglobin in red blood cells that is not bound to oxygen. The previous question, 17, I discussed what is oxyhemoglobin, is that hemoglobin which is already binded with oxygen. So when here comes the term not, that means this is not correct. Oxyhemoglobin by itself means oxygen and hemoglobin together, binded. SiO2 described the arterial oxygen tension or amount of oxygen dissolved in the plasma. Again, here we are talking about blood gas analysis. And when we say arterial oxygen tension or amount of oxygen dissolved in the plasma is what we have as a result when we are measuring the hypoxemia using blood gas machine or blood gas analyzer, so that SiO2 is not oxygen tension. Oxygen tension, we call it pressure arterial oxygen in the blood. So B is not also correct. Hemoglobin has no effects on the pulse oximeter. Again, remember, among the causes of hypoxia and hypoxemia, there is environmental causes. This methemoglobin is an hemoglobin which has been intoxicated by external products. And this also has no effect on the pulse oximeter. This is not correct, because when you are having CO, you are having correct saturation, but you are hypoxemic, as Prof was explaining previously. When there is hemoglobin binded to other external body or other external molecular than oxygen, this will affect your pulse oximeter. A, B, and C are not in our answer. Let us see D. A right to left shunt can occur in lung or through cardiac defect. This, among also the cause of hypoxemia, we had to discuss about ventilation perfusion, where we discussed V2 mismatching, and also we discussed shunt as one of cause of hypoxemia. When we say right to left, that means I'm not going into deep about the anatomy of the heart. You remember, from the left heart, you have the blood, oxygenated blood, and then when you come to right to left, at that time, there is that shunt also, which can cause hypoxemia. I'm not going into details about this. When we say into the lung and into the cardiac, they are into different level. We discussed about shunts. The D is the correct answer at this level, because A, B, C was not correct. Next, please. Yes. A right to left shunt occur when the oxygenated blood passes to the left side. So you, as I was wanted to discuss about this, when you have the return of the blood to the right heart, and then that the return of blood is not oxygenated, is arterial into the from IVC or superior vena cava or inferior vena cava, and you go to the right heart, and when you go to the right heart, you are not oxygenated yet, you are not into that. At that time, you go into the left heart. The left heart, you will pump the blood with no oxygen, and at that time, we will be having also hypoxemia on this kind of shunt. Next, please. Next. Discussed enough. Yeah, we still have 2 questions, and let us have 1 minute here and 1 minute to the next 2 questions, and then we pass the floor to our professor. 2 minutes, 1 minute, sorry. Okay, come back to our question. Which of the following oxygen delivery device is not usually used for adult patients. Nasoprons, all of us here, we are familiar with it. Is used in pediatrics, in obstetrics, and also in adults. I think nasopharyngeal catheter is not familiar, is not often used by our providers here. Oxygen facial mask is also familiar. Non-rebreather mask or oxygen facial mask with reservoir. The 3A, C, and D, we are familiar with them, and we are using them in adults. So the answer simply here is B, and we are going to see why is B. The nasopharyngeal catheter is used in mostly in the neonates, in pediatrics than in adults. I will not pass. I not use too much time on this question. Simply B is pediatrics device. We can go to the next. That is it. As one slide we discussed also when we are discussing about how we are going to escalate or de-escalate about different oxygen devices we are using. And you can go to the next question for 1 minute again. Next slide, please. One minute for you to work on it. Yeah, let's again come and discuss our answers. In the polling, we are having 61% answering the ventricular face mask, and also 33% for a C as the answer. Let's discuss and have a common understanding about what could be the correct answer. Which of the following statement is true about voluntary oxygen face mask? Is used only in infants. When you are in multiple questions, the words or expression like only, always, never, this most of the time is not in the answer. So A is not correct. Is not only used in infant, can be used in any category of patients. B, it requires at least a 20 liter minute flow of oxygen. at least 20 liters minute flow of oxygen. Here also, it's not correct about how the oxygen flow you have to use in this. And you have to remember, when you are having a ventricular oxygen fraction mask, you are having the sum pieces or PS, where you will give the FiO2 according to the PIP you are having into to the patient unit. PIP FiO2 to that piece is not mandatorily governed by having how much oxygen you are going to deliver. Is in terms of FiO2 you will need to determine in the ventricle on the patient's need. FiO2 is determined using air entrainment valve and oxygen flow rate. Is this way what I was discussing about this ventricle, how the ventricle is working? And they are saying the ventricle oxygen infection mask can deliver higher FiO2 than oxygen infection mask with reservoir. I remember the oxygen infection mask with reservoir, which commonly we call it non-breather, is deliver FiO2 to 95% of FiO2, from 60 to 95%. And the ventricle, if you remember it, is a good device with that kind of it can deliver and you can adjust, but the FiO2 delivered here is less than 60. So from this, I think people who answered as a right to answer are more than the majority. I think we have to think twice about what is the FiO2 delivered by any of the devices we are using when we are delivering oxygen. So FiO2, I mean, non-rebreather is better to FiO2 than oxygen ventricle. Next, please. So is this I was discussing about the color you will use and how much the FiO2 you are giving, you are delivering. So you see here, the green is the most having the higher one. Next, please. Yeah, this is the answer we discussed. The last but not the least, 1 minute to think on it. The floor to you, please. 1 minute to answer on it. Let's come back to discussion of our question and the answer. 53% answering D as the answer. Let's go one by one. Which one of the following oxygen delivery devices delivers the highest fraction of inspired oxygen for adults? Here, the keywords we have to think is the FiO2, the highest FiO2. So we have to remember, simple facial mask at 10 liters per minute oxygen flow. Whatever the amount of liters you are giving, the 10 liters per minute for simple facial mask, you cannot be above 60. So this is not the highest. Nasoprongs at 5 liters per minute oxygen flow. Again here, as you remember, the nasoprongs, it has each liters of nasoprongs, you are giving like 4% additional to 21% of the room air, so that you are not is around 30 to 45. This also 60, 45 of FiO2. You are not test. CPAP using 0.5 FiO2. This is a way to write FiO2. Actually, we used to say FiO2 in a percentage, and this is 50%. So this is 50% of FiO2. And this CPAP using 50% of FiO2, again, if you put in, you are having 60, 50. A, B, and C are still not really the most correct answer. Let us see the last one, the non-rebreather mask at 15 liters per minute oxygen flow, as we discussed in the previous slide or previous answers. The non-rebreather mask is the best and can deliver from 60, the maximum of simple facial mask, to more than 95%. And here, if you put it in terms of order, D will be the best answer to our question. Next slide, please. While I'm thanking to the audience, yeah, is this I will discuss. Thank you to the audience for your attention, and the floor to Professor Banguti for the next discussion. Thank you.
Thank you very much, Xavier. Maybe we come back to the second slide for the summary, that slide with chapters. The slide announcing chapters: oxygenotherapy, critical care, obstetrics, pediatrics. So this session, as written, was the frequently asked question. And you could see that despite all the 12 months we've been together discussing those things, there is still some tricks on oxygenotherapy and critical care. And you need to pay attention to understand very well some concept of hypoxia, concept of hypoxemia, understanding the pulse oximeter, which works, difference between pulse oximeter and blood gas, which one is accurate, what is the normal value of a saturated pulse oximeter, what is the inspired fraction of oxygen, what is hypoventilation, what is hyperventilation, hypoxemia in case of COVID, and so on and so forth. So we had some discussion. If there is any question you want to share in the chat, please feel free. Let me check. Is there any burning question? Excuse me for the previous question. So you remember that question number 8, if we can come back to it again. Please, can you move the slide to the question number 8? Hope it is clear now for everyone that the simple facial mask is not limited to less than 6 liters. It starts at 5 to 6 liters up to 10 to increase the FiO2 between 40 and 10 and 60%. So if you are at 5 to 6, you are around 40% of FiO2. Can go higher, up to 10 liters. but the mask needs to be well considered, well placed on the patient to reach the 60%. The more open it is, the more oxygen is going out and the air is coming during inspiration to dilute. So you need to consider the position of the mask on the face. So 6 to 10, not limited to 6. I hope this was well understood. Another one which caused some discussion was about the work of breathing, question number 13. And we discussed about not all work of breathing requires oxygen. And some of you have done some effort, jogging, running, sports. You will have effort, work of breathing increased, but no need for oxygen. You can compensate. But when it comes on the course of disease, acute condition, acute disease, acute impairment, then you may need oxygen so that you don't decompensate. Any other question before we close the session? Remember, for those who need to have this second certificate with CPD points, and I invite all of you to take the quiz. I suggested next Wednesday, 29th. The quiz will be open from 1 a.m. up to midnight. Or you can suggest to start at from 7 a.m. to another 7 a.m. or for those who work very hard during the early morning, we can decide from 5 a.m. up to another 5 a.m. So it will be 24 hours open. Then after it's closed, and when you take the question, when you take your quiz, you have 1 hour on the quiz after it closes. So you need to choose a place where you have good internet flow, you are quiet. When you open it, you have to finish. You have your 1 hour, and after 1 hour, it closes. So you need to be well concentrated, well prepared to take your quiz. So if you might get 70% and you've been attending for 75% of your attendance, presence, you have your certificates with the whole logo of other international universities, and you have your CPD marks. So please let others know that this opportunity is open and we can all benefit. Is there any question, clarification? How much CPD? 20, because there was 10 for the first part. This second part is 20. So if no question, no suggestion, Alana, the floor is yours. Alana?
Yes, thank you. If you would like to access the resources presented today, including recordings and additional quizzes, exercises, and videos, we encourage you to create a free student account on the Learning Resource Center. The link will be shared in the chat shortly. And although this is our last session, we encourage you to continue engaging with the content and using the WhatsApp group to ask questions. So if you come across questions or challenges in your clinical work and you'd like to ask a question, the WhatsApp group will continue to remain active. So thank you so much. This is the end of the series. Our team at Assist International and Project ECHO are currently working on potential new programming. So stay tuned for the new year for news about that. But until then, happy holidays. Thank you so much for your participation in the program this year, and we hope to see you in the new year. Thank you.
Thank you.
Thank you.